Welcome. Good afternoon. Welcome to those watching us through Polycom and through our website, and a special thanks to Dr. Watson for joining us today. It is my pleasure to have one of our own speak to us on the current population health status in Hispanics, Dr. Melanie DeBoer. She is an assistant professor of epidemiology and in the Department of Preventive Medicine and Community Health. Dr. DeBoer received her Bachelor of Science in Microbiology from the University of Arizona and her PhD in Infectious Disease Epidemiology from the Johns Hopkins School of Public Health and Hygiene. She comes to us from the World Health Organization, Pan American Health Organization, where she served as field epidemiologist in prevention and control of infectious diseases. She has over 20 years of field experience, primarily in Latin America and the United States, U.S.-Mexico border region, but also from Asia, where she completed her thesis characterizing heterosexual risk factors for HIV transmission. Prior to her term with PAHO, she served as research fellow with the CDC, where she continued her research in HIV transmission and clinical treatment studies of infected women. Her current research interests include the intersection of wildlife diseases, infrastructure development, and the emergence of infectious diseases, the implementation of the international health regulations to detect those pathogens, and the development of advanced epidemiological methods. She continues her collaboration with the National Institute of Public Health in Cuernavaca, Mexico, and the Mexican Secretary of Health, assessing the root causes in the decline of malaria rates in that country. She is the chair on several Masters of Public Health capstones focusing on emergent infectious diseases and serves on multiple doctoral candidates' dissertation committees. During her tenure with PAHO in Mexico, she was mentor and committee member to numerous doctoral candidates at the National Institute of Public Health at the National Autonomous University of Mexico. She was recently named the director for PAHO Collaborating Center for Training in International Health and serves as co-director for the Public Health track for medical students. Dr. DeBoer is a United Nations certified bilingual in Spanish and speaks basic Dutch, French, and Thai. Please join me in welcoming Dr. DeBoer.
Well, first of all, thank you for that overly euphemistic bio summary. I really do appreciate being invited today. I consider it an honor to be among this group. Part of my job today, and if I need to speak up, please let me know. Part of my job today, the way that I look at it, is to sort of walk you through how I, as an HIV epidemiologist, ended up getting into vector-borne diseases and how my interests sort of flowed from the border and how I became so embedded into research in Mexico. And part of this, my approach is to walk through several of these diseases to illustrate successes and challenges, and from my perspective, just plain fun, because I do this because I love it. I'm one of those people who get up every day and get to do what they love to do, albeit being stressed out and writing these sorts of lectures right at the last minute, because we're all so overwhelmed here at UTM, thankfully. So I'm going to walk you through a couple of these case studies, and again, if you want to correct anything on these slides, because I'm human, you can always find me. Just Google me on the UTMB website, and you'll find me. But there's two things I just want you to keep in mind as we go through these slides, because they'll pop up later and they're relevant. One is the little corner here, this is Arizona. Sonora is totally contiguous with Arizona, with the little boot of New Mexico. And my last name happens to be Dutch, and my father was originally from Holland and immigrated straight through to a tiny little town, which I'll show you in a moment, and it literally means the farmer, and it'll come up again later on when we talk about brucellosis. Whoops. So to give you a little bit of where I got into this, as I said, my parents emigrated. This is Arizona. Texas is over here. I got to Texas a little late in life. But they decided to settle down into this tiny little town, and this is the Google version. My home where I grew up, and we still have that home, is here. This is the Mexican border here. And as you can see, the town here is called Agua Prieta. My parents are buried here. I think I went to high school here. So, you know, I'm a border rat. That's how I got into it. It wasn't an interest. It's just part of who I am. And being in a city of 3% white, you know, I am about as gringa as they could possibly get. But so I've always been in a minority position, and that's the area that I feel more comfortable in. So Texas is also a good fit for me, as is Galveston, because we have such an enriched variation of culture. And the other thing that I wanted to bring out is, how did I get into infectious diseases? Why did I like this? Well, this area of the world is a hotbed of valley fever. And when I was 16, I came down with a raging case of coccidioidomycosis, and I fell in love with the mycobacteria. And so I embarked from that point on, and I had the luxury of having a very great local primary care doc as a mentor, and mentored me through. And then, as luck would have it, my degree program in Arizona had an excellent medical mycobacteriologist. So that was sort of my launch point from that, to give you a little bit of context. And I wanted to kind of get that out of the way, because that's the answer I'm almost always asked. How did you get into this? And it's not how did I get into it, it's like I keep trying to get out of it more than anything. So if you jump forward here, I'm going to cover a little bit on, I'm trying not to move away from the podium, but I'm going to cover way too much in this, and it looks like a couple of things were blanked out on this slide, and I apologize. This is a fast forward after I finished my doctoral thesis and did a couple of years, as Dr. Norma had so nicely described. I spent 2 years at CDC and then jumped right into the WHO in Mexico. And this was about day 3 of on the job. I got sent out to the field with no notice. And as you can see, this is sort of the Sesame Street version of what doesn't fit in here. There's one woman standing in the middle of a bunch of men who are ready to go out and start spraying for malaria with pyrethroids. And there I am standing in pantyhose and heels. Yeah, isn't it? And it sort of encapsulates my entire experience in all, not just in Mexico, but all over Latin America and Asia, and even in the United States. Frequently, I'm the last girl standing there. But that literally was about day 3, and I'll get into a little bit of the background. But I'd like to talk a little bit about the CDC BIDS program, just give you a brief introduction, because that really is the cohesive federal level infrastructure for this work. And you have to at least know about it to understand the dynamics of what's going on. So this is a very, very busy slide, but basically the Binational Infectious Disease Surveillance Program got started off at a very, very rocky start way back in the late 1990s under the auspices. It really began as a group called TED Against TB, and it was 10 border states that were very concerned about tuberculosis patient care among the immigrant population, because Mexico follows the WHO recommended regimen of tuberculosis medication, and we in the United States we do sensitivity studies and then we prescribe the medication. So there's difference, and they come and go, and so that's how this group really started. And as time went by, they began to they being the Centers for Disease Control and the Secretary of Health in Mexico realize we need to have a much more cohesive system. Also, in the meantime, September 11th happened. A spin came in on border security and border health. We conducted a lot of different trainings. WHO collaborated with the border states and with CDC taking the leadership with the Secretary of Health in conducting very fast alert systems and how to triage with varying levels of success. But I would very much encourage you to read a little bit more about this. The focus right now is on influenza, but the main, as far as actual surveillance, but for me, the aggregated value of this is the fortification and the interchange of laboratory technology. Just getting a lot of their regional labs on board on speeding up the time of doing diagnostics, and also the more transparent sharing of surveillance data back and forth. And again, that's been to being varying degrees of success or not. I see some laughter in the back of the crowd, so I'd imagine that they know a few backstories that I could share. So I'm going to start out with malaria because this has become my area of interest. And this is an example of a success story from my perspective, or one of the success stories that would be useful to capitalize to study and to understand why it's successful and how we can transfer their approaches for malaria control into other countries. Of course, the first that comes to mind is Central America. And if you look, there's a trend. This is the line of the rates of malaria through time. And in the yellow bars are the tons, the insecticide use in tons of DDT. Now here we see a dip in the use of insecticides, and that's because Mexico decided to decentralize their it's almost euphemistic to call it centralized, because everything was centrally run in Mexico for the health systems, for surveillance, for indigent clinical services. Everything was run federally. And it worked to varying degrees in different sectors. It did not work so well in the health services delivery sector. So here you see a big jump in the number of cases because of the old adages we saw here in the United States with tuberculosis. You cut down on the amount of funding that you have to control and prevent a disease, you're going to see it come back, and that's exactly what happened in the mid-'80s. And then we saw a continued decrease when they started to refund through time, and also a switch from DDT to pyrethroids for spraying for mosquitoes, and that came about because of NAFTA. It was a requirement under NAFTA that Mexico get rid of their stocks of DDT for use in insecticide spraying for malaria control. That was a non-negotiable. And there was a lot of controversy to that, and Mexico took the leadership. It was funded by the Global Environmental Fund, and they were able to destroy about 95% of all the existing stocks. There's some remaining because the stocks were so degraded they couldn't get rid of them. But if you blow down, and again they went through and they initiated a more robust effort to decentralize health services in the country. So if you and here is the marking point in about 2000 with the elimination of DDT altogether. So if you blow up this little section here, it shows the drastic decrease, and we see a little bump here in 1998, and we'll get to that in a second. And these are just the actual numbers broken down for if there's any malariologists here that by Plasmodium vivax and Plasmodium falciparum. But the summary of this table is that you see almost a 90% reduction in transmission from 98 to 2009. They totally interrupted the transmission of Plasmodium falciparum, and about 3/4 of a reduction in the number of municipalities, and that's roughly analogous to our counties. To varying degrees because our counties vary from state to state, but it's uniform in Mexico. There's about 3/4 reduction in those municipalities registering cases, but in the last couple of years there's been a slight increase, and we'll cover that. And this is just the chart for Plasmodium falciparum, which is now pretty much eliminated out of Mexico. And this gives you the geographic distribution of malaria in 2010, which is sort of, they've already closed out that epidemiological year. As you can see, we have some here in the north along the border, but it's now concentrated primarily in Chiapas. And this is just the numbers behind what I just showed you. Again, Chiapas, Oaxaca, and Chihuahua represent about 80% of the cases in the country in 2010 at any rate. So there's a little bit of a focus on Oaxaca, and that's where my research is now. And we're using that as sort of a test state because there's been such a great success there. And that picture that you saw of me and all the men was taken on a bend in the road right, I'm guessing, right about here near Huatulco. And that was taken, I can tell you almost exactly, about March 20th of 1999. And the reason why we focus on that is because of something that we're all pretty familiar with here. In October of '97, Hurricane Paulina hit, and in terms of destruction, it's the most deadly and costly hurricane coming in from the Pacific side in history. And it did a great deal of damage. You go back even today and you still see some of the effects of it. Most of these pictures were taken in Veracruz, but some of them are taken in Oaxaca. And you can see the malaria cases jumping from 1907 to 2004, and you see that large peak this happened in 1997, but the real peak hit in early 1998 because of the reservoirs of water. So that's why we're focusing on that, and it became a test case. So in 1998, they had over 17,000 cases. And my vernacular of looking at the way the Mexican federal government approaches these control systems is sort of the Nike approach. They just go in and do it. They don't use a lot of scientific evidence. They read the literature. They take from it what they can that seems to make sense to them, and they put together a program. And Dr. Jorge Mendez, who was the director of the vector control group at the time that I was working there, put into control a couple of, he had a three-pronged approach. One was two of them were very community-based and based on education. Bathing every day, with the presumption that when you don't bathe there every day, you tend to attract more mosquitoes. Another one is as you can see the women up there, and this is not gender skewed, there were truly a lot of men out there as well. This just happens to be of women. They would go out and they would rake up in their communities all of the algae growing in and the biomatter that were growing in their streams that served as what's the English word, the criaderos, the breeding sites of the malaria and the pupa. So the idea being you clean those out, then you have less growth. So they did a lot of work on that. And also, they instituted what they called patio limpio, which literally translates into clean patios. And they would go in and train people not to have standing water in their plants around their front porches, to cut the vegetation around, and so forth. And they also had presumptive treatment with follow-up. They had a community worker, which I'll show you, that did the presumptive thick smear and would send it into town. And then they would be a member of the Secretary of Health, which is the SSA, and the EAMS is their Social Security, their insurance system for state health workers. They would send somebody out with the medications and do actual follow-up, sort of like the tuberculosis directly observed therapy. And they had a couple of not crazy, but novel treatment schemes that were never really tested, but preliminary they think were pretty efficacious. But now they've passed through that acute phase of the epidemic, and they've stopped some of these alternative treatment schemes. So, and just as a note, to give you an idea of how much off-label use there are, all of the primaquine and chloroquine are provided free of charge, and they're usually only available through the Secretary of Health. So you've got a point source and you've got tight control over it, so you don't have a lot of your background evaluation blurred by pharmacy access. So another thing that they did, and this ties into a couple of the other vector-borne diseases, is they trained 250 microscopists around the state, and they're only around the country, and they're only trained to do three things: looking at thick smears, looking for Leishmaniasis, and looking for Chagas. As malaria declines, they start looking for Chagas, or Chagas and Leishmaniasis. And just because I come out of a lab, the quality control measures were all of the positives were sent to the national laboratory, which is called the National Institute for Diagnostics and Epidemiologic Reference, and 10% of the negatives for control measures. And I was thinking a lot. I don't know how many of you here in the room went to the discussion last night on ethics and the challenges of medicine and treating patients with little resources. This is an area. I have to applaud the two gentlemen who gave the lecture, and both of them happen to be both MD and PhD students, and it's a good crossover. And this is a good example of how you can learn from other cultures how to mobilize the communities at very low cost with very good results. So what they did is they would go in, as you can see, this is where this woman lives, and I had quite a lengthy conversation with her that led to my research, so I owe her a lot. They would go into these communities and give them slides and a needle and teach them how to do thick smears. And if they had a febrile case, all the community members were trained, go to this woman, and she'll take your test, and then she would send it into town to be read. Now, there were lots of problems. They had to, they would use dirty slides, and they were, some of the slides that were taken were useless because you had grime built up on the used slides and so forth, or the sample was inadequate. There were lots of problems, but it was the best they can do. And so she was the point person, and she actually took like a mini surveillance just on a piece of paper and listed out everybody, old school, like when I was being trained in a lab, just writing down a log of name, date, a birth date, gender, and when they became febrile, and it worked very, very well. And one of the comments that she made to me when we were doing an evaluation of the program, of course, one of our functions at WHO is to go in and ask, we respond to the Secretary of Health's requests for help. And one of the things they requested was an evaluation of whether these programs work. And my job was to put together an expert committee. And I'm not a malariologist, so I went out, and there was a fantastic crew that came in from WHO. Dr. Novato, who used to be the head of the WHO malaria group, came in out of retirement. Kent Campbell was involved peripherally. Keith Carter, a whole bunch of very smart guys. But of course, they're all men, and they all went into another room and started looking at the maps and the distribution. And I stepped outside and talked to this woman, and I asked her, what is the number one thing that you think determines, why do you think your rates in your community are going down? And she said to me, well, and this is through an interpreter because she didn't speak Spanish and I didn't speak her native language, but she said, well, they finally built a road. It was a paved road, and then there was some enterprising capitalistic young man who got the money together to buy a little truck, and he had a little taxi service. For 10 pesos, you could run into town and run back. And so every day she could send in the slides and send them back. And he did it free of charge as, service to the community. And for my mind, everything gelled at that moment, that's where the money was. You had infrastructure developing very quickly in that country. From 1970 to about 1990, huge strides made, and I'll show you some graphs in the growth of highways, paved roads, dirt roads turning into paved roads. The distance to take to get from this area of the country, from Oaxaca City to Mexico City, when some of my family used to live down there, used to take 8 to 12 to 16 hours, depending on the weather. Well, now it's a superhighway and it takes 4 hours. So there's all of this kind of environmental level activity going on that contributes to the rates, and it's not just the activities of the government. So anyway, I'm spending way too much time on malaria, but this was my aha moment, that what she's doing is cutting down the time of parasitemia, because she can get the lab results back in a day, and they would send back the presumptive treatment. She could get these people treated while they're still febrile, and so their parasitemia time was cut way short. So at any rate, there launched my career when I got into UTMB. On the other side of it, so you have these very rustic communities, and these are charts and graphs that were created by my colleagues down in Cuernavaca, who were the two gentlemen standing on either side of me in that second picture. And they have these, wonderful tools to analyze the data they have. They just don't know how to analyze it very parsimoniously. So you have these very, very big extremes. So we decided to start collaborating. This, I'm not sure if this presents too well, but this is at least an art view. It's not the ideal source, and this is part of the problem with one of the older analysis. In red are the smaller highways, and the white lines are the areas of the state. And what I can't see on this screen, but on the back screens you can see a lighter set of roadways coming in through here that are actually highways. And there's highways coming along here as well. And those have all been built probably within the last 15 years or so. And this is the distribution of the cases over time in that. So I learned how to drive. My father, when I was 16 years old, took me into Mexico and handed me the keys to the car and said, learn how to drive. You can drive here, you can drive anywhere. And there began my love and passion of highways, in particular in Mexico, where it truly is, sadly, a blood sport, which, and even more sadly, I enjoy greatly. So I turned to the Secretary of the Secretary of Transportation and Communication to get better data. They have time sequence data when they built roads and when they fixed roads. So I'm in the process of putting in the rates in conjunction, building a data set that will join these two data sets together. So that's one area. And just to give you a quick idea, because just based on what's available on the internet, I just did a couple of our statistics, but it's pretty well correlated. The more paved roads you have, the lower in red is the incidence of malaria, and these are the number of municipalities that are positive, and this is the growth in highways, and they distinguish between concrete and tarmac highways. So that just kind of gives you a broader context, and this is by type of roadway. And just for fun, because I love technology, and also to kind of to show you profoundly how things are changing and how we're becoming very similar. Just because I had the data handy and I was curious, in red you have the number, in blue you have the increase in number of internet users in Mexico. So it's an indicator of development and communication and how fast things are turning around in that country. And they're absolutely inversely correlated. So part of my hypothesis is you have a lot of development going on, and these diseases are associated with that somehow. The Brazilians did a very good study which kicked off my research, but they showed an inverse correlation. The closer you are to highways in the Amazon region, the higher probability you are to get malaria, and they think it's because of you have vulnerable migrants flowing through high-density malaria areas. So we have slightly different twists, but the same idea. And this again is sort of the current status of where the nodes are. And I just wanted to point out where there's another global aspect I'd like to point out. They're, of course, seeing all these drastic drops in malaria rates, but there's still nodes of here in the Zacatecas corner here. They just, in November, started quite a significant epidemic, but they can't get to these people. Does anybody know why? This is the narcotraficante area, and they have complete power over it, and the only people they're letting out are the children and the women to get treatment. So there's all this sort of these sorts of macroeconomic challenges that we have to face. And another point that as an aside, that why we have to look at the broader picture, is generally what happens in Mexico is reflected to a certain extent in these illnesses in Guatemala for certain, because Chiapas and Oaxaca down to Panama is what they call the Mesoamerican region. And they have a lot of cultural identity in common, a lot of differences, obviously, but there is a lot of analogy that can be drawn, and they do exchange data, and there is a lot of migration that we get up from Guatemala. So moving on to dengue, and I'm going to come back to dengue. Dengue is a very challenging area for me. They have all four serotypes circulating in Mexico at the moment, and this is just a little bit of the background. I'm putting this up here because it relates to the final group of vector-borne diseases that I'm going to discuss. And this is the history. There were several eradication campaigns that look like this. So in the 30s, there was a huge problem. In the 70s, again, they threw a bunch of money at it. In 1998, between 1970 and 1998, they stopped putting money into global funding for it. So of course, you're seeing a resurgence in it. And for us in the U.S., what that means is just in September of last year, they had the second autogenous case that was reported in Miami-Dade. I don't know if you heard about that, but there have been two so far in that area. No history of travel. Certainly somebody came in with it in a mosquito area, and then the mosquitoes became infected and infected several other people. And within the most recent data I could find was between 2006 and 2008 with 244 confirmed cases, and almost all of those, with the exception of these 2 or 3 cases that go back as far as that as well, were confirmed and probably related to cases travel related outside of the U.S., mostly in Asia, but somewhat in Latin America. But we have the vectors here. If you haven't walked around Galveston Island, you're missing something. And this is a distribution for dengue incidents in Mexico for last year. And as you can see, we have dengue up in the north of the country as well as in the south. And one of the questions is, I find it very hard to believe that some of the febrile cases that you're picking up in San Diego or Tucson or El Paso, I find it very difficult to believe that none of those febrile cases are dengue. I just don't.
You don't ask for vaccination. Where the virus is, you know,
Even in adults, and usually it's self-limiting anyway. And the biggest challenge with dengue, and that's why I don't want to labor too much about it, is their surveillance is based on clinical. It's not laboratory confirmed. And I've yet to get well, it varies by region what the percentage of laboratory confirmed cases are. And most of those are focalized studies that have been done out of academic institutions. So it really, the rates are probably underreported, but they're also probably overreported for another reason that I'll get to. And just a little bit about onchocercosis, because I view this as one of the big wins. What they had up until the 1990s, 3 main foci in Oaxaca, northern Chiapas, and southern Chiapas. Now, after 22 consecutive rounds of Mectizan, where they would go out in the community and they would treat everybody with this, Now, northern Chiapas is now considered eliminated, has now eliminated onchocerciasis. And Oaxaca, I was just in a meeting in December, and I was speaking to the vector control officer there, and they now just started the process of getting their certification of being free of onco. So that was, having worked so much in Oaxaca, that's my go-to state, because they just kind of jump in there and do it, and they were very proud of that, and rightly so. So there's one remaining foci with that. But the thing I'd like to point out here was this was a collaborative binational effort, mostly out of the Carter Foundation, but with PAHO's assistance, because PAHO sort of helped them get into these hard-to-reach areas. And President Carter came down. I had the pleasure of meeting with him. And, with funding from the Lions Club and now the Gates Foundation. It wasn't at the time when I began working on the project. And Merck donated all of the medications. So it really was, from what I heard yesterday, a lot of the certainly the residents and the medical students get very, very frustrated that nobody's serving these populations. But this is a case where they are, and they do care, because President Carter looked at it and said, there is no reason we can't get rid of this disease. And he worked very hard about that. And of course, I went to that with my politically conservative husband, which made it a very interesting. He served under the Carter administration and wasn't as in agreement nor as optimistic as I was about working with Carter, but it's another side story. So this is just the geographic distribution of onco as it stands at the moment. Again, in Oaxaca, this is a distribution of people that they consider at risk, that are still living in areas where the vector is still being detected. So as you can see, there's still quite a large population that are at risk, but the number of actual clinical cases is diminishing. Chagas, I wanted to bring that up briefly as well, because my second level supervisor in Washington, D.C., when I was working at PAHO, gave me a bit of advice, and I think it's true for anybody in any career. 98% of your time you're miserable because you don't see results. It takes forever, you lose the game, you moving slowly, but once in a while you have a win. And it is a thing of beauty when everybody comes together at the table to do something. And one of the things that the Secretary of Health did right, that I helped them pull together, is integrate. They had different groups of researchers. We're in an academic institute, and I think you can appreciate the silos we all work in. There were silos all over Mexico looking at Chagas, collecting their own surveillance, their own prevalence data, but they weren't reporting it anywhere. So it wasn't doing the federal government any good, because they needed that information to develop prevention and control programs. So what we did is we called them all to the table and said, okay, you guys have got to stop protecting your data and send it to us. You have to start working together. Get your protocols to be comparable. And they finally did this. And a lot of this information was in the Lancet. Roberto Tapia was sort of the analog of being the head of CDC in Mexico at the time that I was working there. And really, one of the reasons why I was so proud of this project is he let me do what I wanted to do and pull these people together. And there was a lot of criticism in the Lancet that Chagas was still a public health problem in Mexico. And it is. It's a huge public health problem, and it is a big concern. However, it's not like the federal government is doing nothing about it. They're doing a lot of things. They pulled these groups together. They've now they've put in an active surveillance system. They screen all their blood donations, and they've integrated, as I put into a previous slide, they've integrated Chagas surveillance, active surveillance, into their malaria control programs. So they're starting to get very good data about what the prevalence rates are to T. cruzi antibodies. And let's see, is it on this slide? Yeah, it's stabilized at about 0.5% over a 5-year period. So, and that's pretty much true. It's focalized, but it's still a problem. But at least they know it, and now they can move forward with something to do about it. And the criticism was, well, the federal government's not doing anything. Well, that's more, the gesturing of a lot of people that that really weren't familiar with the activities. So how does this bear on us in the United States? The vector-borne transmission is truly rare, but the American Red Cross went in and did an antibody prevalence screening among their donors, and that the preliminary indication was that a lot of their, well, not a lot, but a significant number, enough to concern them, were turning positive. And so that initiated a large study of between August of 2006 and January of 2007. And as you can see, 61 individuals were second confirmed. You have to go through 2 sets of testing to be confirmed positive for Chagas. So I think this will give you a little bit of an idea of how it looks in the United States now, because now all the Red Cross blood banks screen for it. So their problem is our problem. And you can probably guess the demographics, although I don't have access to the data. You could probably guess the demographics of those blood donors. No, that's a very good question. I would be willing to bet at this university they do, because of the demographics of the island population. Frankly, it depends on who the blood donors are. If they go through a screening process and they say, I haven't been out of the country for so long, or I'm from Mexico, and I lived in a rural area, because it's yeah, that doesn't make any sense to me at all. But of course. Well, I'm out of that. Oh, I was just going to go donate blood too. Thanks. Now I'm out of it again. So also too, there's all this discussion. What is a vector? And for me, and you talk to some researchers here on campus, vector-borne diseases are mosquitoes, the chinche bugs for Chagas. To me, if it comes from another animal, hairy or not, it's a vector-borne disease. Dr. Fullhorst and I are sort of the ilk that if it comes in another life form and brings it to me, it is a vector-borne disease. So I had the opportunity to work a little bit on this study on scorpion bites, and this is some of the background statistics, where you have about 1,500 scorpion species worldwide. Only about 50 are dangerous. Here in the United States, we only have 30 species, and only one is dangerous to human, and it's called the bark scorpion, which I'm to this day, I stand on my bed when I get out and I jump off the bed, because when I was a kid, in a rural area, you always have scorpions under your bed. And then, of course, you're probably familiar with the mortality and morbidity rates, but in adults, it's not that much of a problem, but where it is a big problem are the young kids, because of their body size. And about 3/4 of those occur in rural areas. And in the United States, we have about 15,000 bites. Only a few hundred of them among adults have severe symptoms. But the highest, and here again, this is the interplay between the United States and Mexico. Some of the highest recorded mortality, up to 1,000 a year. I think it was back in 1997, and I think it was because it was after a year of drought, were recorded in Mexico. So again, there opened an opportunity for collaboration. And this is sort of how it played out. Because Mexico had this high mortality rate, they have the BioClone pharmaceutical company, which I worked with directly. Their two brothers run the company. One kind of runs the business end to make money, and the other one kind of deals with neglected diseases and orphan drugs. And one of the orphan drugs that they were very interested in working with was scorpion bites, but they didn't have a way to test it because of the operational challenges that they faced in Mexico. So I introduced them to Leslie Boyer, who is a physician and toxopharmacologist at the University of Arizona, who runs she's one of the leads in the Poison Control Center there. And they began a collaborative effort to test an antivenom. And that began probably in about 2006. And so, as you can see, as of August 3rd, the FDA approved that antivenom that is now going to be produced by Anascorp in Tennessee. So that's another sort of win-win situation where we have a very highly skilled poison control center that can offer services to collaborate and to build these cooperatives. And they tested it on over 1,500 patients, both in California, Arizona, and in northern Mexico, mostly Sonora and Hermosillo. And they were able to do this very, very quickly. They did a lot of consults by telemedicine. But again, it's an example of how you can run, you can synergize a problem in one country and pull together a similar challenge in another country and utilize both sides of the line to get something done very quickly. Because going from I would say I started talking to BioClone probably in 2003, just preliminarily, and then get it to FDA approval by 2011. That's pretty rapid in the big scheme of things. And they're the only group that does this now. So they're going to be providing, it's going to be a big money earner for both of these companies because they're the only place on the planet that provides it for India, Africa, all the other countries. Everybody's seen this slide on West Nile, and this is my example of we can give as good as we get. Of course, everybody remembers that West Nile came to us via bird migration up to the northeast. And I'm going to refer down to my little hometown because it's another prestigious area, which I'll refer to in a minute. So last year we had 43 deaths and 690 cases, and of those, 15 of the 43 deaths were along the border states, and 252, or 37% of the cases in the United States, were along the four border states, mostly in California, then in Arizona, and then in Texas. And then this is the spread of, this is the prevalence in the bird populations last year. And the source of this, I don't think I have it, is the USGA. Now, this is actually work done here at UTMB by Jose Estrada. And he went and he surveyed ravens and horses. And this is the distribution that he got for West Nile virus in Mexico. But when you look at the reported human incidents in Mexico, nada. not a one. And we have been arguing with the Mexican federal government about this for a long time. Part of it is they don't have the resources to test for it. The other part of it is a lot of the dengue that is underreported because they're not they're not laboratory diagnosing it. It may be overreporting because some of it might be West Nile, because clinically they're fairly similar to each other. So it's hard to say. So this is another challenge that we have to kind of overcome through time. And there's another disease in the mix that is going to complicate matters even further. I work a lot in rabies only because I like a good excuse to get out on the trails, particularly in sylvatic rabies. And I'll be working with Chuck Ruprecht, who's in charge of the rabies control program at CDC. They're trying to get a dual rabies contraceptive vaccine going, and once they have that going, we'll probably test it down on the border, and that's sort of my interest. The interesting thing about rabies is that Mexico is much more successful at controlling human rabies than we do. Having said that, we usually have probably 2 or 3 cases, maybe 5 or 6 every year of human rabies deaths in the United States. Well, the last recorded case that they had that I could find in the literature was 2009, and before that it was 2006 in Mexico. They just don't see that much human rabies cases. And it's not because they're not looking for it. It's because they have, what they've done right that we don't do is they have integrated their dog and cat rabies vaccine program in their federal human public health program. Where here, the rabies vaccination it's voluntary. You take your dog in and you do it. In Mexico, the federal government goes in and has these huge campaign programs. They stopped for a few years. They realized that wasn't going to work, and they brought the money back to do that. So that's a lot of why they don't see that. The other reason why they're great collaborators is they have vampire bats, and bats are the biggest reservoir for rabies in the U.S. I mean, in Latin America, and we don't have that. And this is just sort of the line listing of all the rabies cases. It's hard to see. But as you can see, we have a fair number of rabies cases in Texas. The ones in orange are the ones who actually survived it. That first case in 2004 is that Gina Giese case that was the landmark case where they actually sort of thought outside the guidelines and figured out a way to save her. And that protocol was instituted again, I guess, in 2010, and was able to save somebody else on that same protocol. I'm running way over time. Pardon me? They put him in a coma, yeah. Yeah, I don't know. I'm not familiar with that case. We'll have to discuss that one later, though. But anyway, the point being is that, most of it comes from wildlife, and they obviously do not observe cultural and political boundaries. CDC has been trying to work with SAGARPA, which is their equivalent of the USDA and the USDA, to get wildlife surveillance for rabies along the border. But with limited fundings, they haven't been able to get that off the ground. I show this only because, as you can see, you have a fairly strong growth curve with bats, and that's where you're going to see it being brought in. And another area of collaboration, this is Central America as well, and just another emphasis that what you see in Mexico you pretty much see in the other countries. And in the blue down at the bottom is the rabies cases for Mexico. Every couple of years when we have the money, because we don't have vampire bats, this is a vampire bat that picture I took at a training. We bring in American USDA officials to learn how to trap vampire bats, because we're going to get them. We got that one vampire bat variant in Louisiana a couple years ago. And we need to have trained workforce in the United States to figure out how to handle vampire bats. And if we have another training, I'm going to find some money to take some students, because it's a very cool thing to go through. You do this in the middle of the night, you trap a couple of cows, and they come in, and it's the creepiest thing ever, because they're land hoppers. They don't fly in, and you can hear them flopping on the ground, and then they flop up onto their victims, and this is what it looks like. You turn around, and in a second they're gone. So if I get some money, we'll go down and do that. This was in there's a huge cave in San Luis Potosi that harbors these bats. So very quickly on brucellosis, we do get cases here in the United States. They're very notable, less than 100, but it's almost always from artisanal cheeses coming out of goats in Mexico. And so that's where we have to kind of, and almost always in California, again with more the organic food eaters. And this is why I wanted you to pay attention to my name. So these are goats that are used for them. There's huge brucellosis vaccine programs going on in Mexico. And they're very interested in having their goats vaccinated. And the reason why is because it causes abortion in their herds, and they want to minimize that. And the problem is the coverage, because you get everything from goats wandering around in the fields, in the desert, to concrete compounds where you have 10 to 20 head in a 10 by 10 area. So the control that the government would have over these vaccine programs varies greatly. But curiously, does anybody know what kind of goats these are?
They're Boer goats from South Africa.
That's right. Exactly. And that's, my name means the farmer, and these are farm goats. So it's going to be easy for you to remember. So very quickly on leishmaniasis, because Peter Melby could tell you much, much more about this. It is still, a public health problem. It's still a public health problem, and it's in 22 states. And it's rare in the United States, but it has been seen in rural Texas down along the border. And curiously enough, again with the binational collaboration, the United States donated, there's these heating elements for visceral leishmaniasis that you apply to kill the parasite. And those machines need maintenance. Well, the only company that does that is in Phoenix. So I literally would get on a plane, get them to Phoenix. They would refurbish them. I would visit my family and fly back. The problem is that the Mexican government has a regulation that they will not accept used equipment as donation. So once it's left and comes back, it is now a used piece of equipment. So I am an instrument traficante. That's where your diplomatic immunity comes in handy. But that's the kind of thing that you have to pull off on the border to get around these things. And this has been going on for years and years with TB medications.
You referred to the number of states several times. Are you talking about American states and Mexican states?
No, this is just in Mexico. You don't see it much here, as far as I know. Does anybody know? Yeah, this is 22 out of, there's 31 states plus Mexico City. So those 22 states are the 22 states in Mexico only. Sorry, I should have clarified that.
So there are 22
Where you find prevalence of leishmaniasis, and you get it from dogs or usually from dogs. It's a huge problem in Guatemala because they have so many dogs on the street, and that you almost always see leishmaniasis among the little kids. To varying degrees, some of them overcome it, but. I'm sorry, pardon? Yes. Yes, exactly. The dogs get it through sandflies, or you can get the biggest problem in the United States, which I'm not bringing it up too much here because it doesn't pertain to the border, are from the troops coming back from the Middle East. That's the biggest prevalence problem here in the United States.
But you're saying it's the sand fleas from the dogs?
The sandflies bite the dogs get it, and then the dogs hang out in the houses with the kids. And just to kind of finish up here, because I'm just now getting into this and tying it together with the dengue and West Nile problems, Dr. Fullhorst there's a long history of unknown febrile illness in epidemic proportions historically, primarily in northern Chiapas. And he is putting in a proposal trying to weed out the ecology between, the common wisdom is that you get it mostly from rodents. It's very similar to hantaviruses, and the testing is very similar to hantaviruses. And actually, they put it on the same panel and they test them simultaneously. But his thinking is that it makes more sense that it was brought in by bats, and bats are just essentially rats with tails on them, and wings. So he's trying to figure out the ecology on that, and I'm putting in an R21 in July to look at the prevalence in the human population after he's finished determining what communities are positive in the rats and bats populations there. But it's very similar in presentation to dengue and West Nile in febrile presentation. So our thinking is the surveillance systems need to get in 20, 30, 40 years when there's more money dedicated to these things, that their surveillance system will start testing more. And part of our objectives is to develop their laboratory capacity to test for these arenaviruses. And this is just another reference to give you. And to give you an idea of how far back this goes way back into the 16th century. And a lot of this was done by tree ring analysis, looking at drought cycles in tree rings and when they must have had huge population growth in rodents, and whether or not you had subsequent epidemics in febrile illnesses through the centuries. So it's got a very, very rich back history for that. So just since I'm a few minutes over time, sort of how I'd kind of like to end on this is, obviously we can't treat these diseases as though they're cultural or regional boundaries. And also everybody talks about the epidemiologic transition. And everybody, we're moving toward diabetes, and I did a lot of diabetes work because that was the urgent call from the government for my work, and I can appreciate that. But I think that there's a lot that we can learn from that, from these technical collaborations along the border, and looking at the different patterns of health service utilization to see where people are going to try and figure out what they have, and to sensitize physicians on this side of the border and physicians on the other side of the border on what to test for. Because I can guarantee you in Chiapas, they're not thinking arenaviruses. Everything is dengue for them. And to remind people, there's a strong history and a long, lovely history of collaboration between the two countries, both at the microcosm level, at the local level, and at the federal level. As much as I like to argue with my husband about the State Department's role in the United Nations, they still have played a the State Department really has driven a lot of this technical collaboration between the two countries. And there's the USDA and the APHIS, which is the Animal Plant Health Inspection Service that manages the wildlife surveillance systems. They're embedded in the U.S. Embassy in Mexico as well. You know, some of these diseases are diminishing in incidence and prevalence. Some are remaining stable, but the fact is some of them are emerging. And I think we can work together. Dr. Fullhorse is finding the same arenaviruses here in Texas as he's, you know, as in not exactly the same strains, but the same types of things in Chiapas. And we're really beginning to work together to look at the similar patterns and migration routes among these animals and vectors to really work out what is the epidemiologic profile. And it is quite lovely because when you're discovering these new niches of viruses, there doesn't seem to me be as much political backlash for that. Finally, to end on a more positive note than perhaps yesterday's discussion went, we have a lot to learn from each other. I think I've learned more from my collaborators in Mexico than they will have ever gotten from me. And there's a lot, maybe I'm being overly optimistic about all the young people here in the room, but I truly believe that you people all sitting typically in the back of the class will come up with really great novel ideas on how to resolve these issues with very, very limited resources. There is no reason that we can't do this. They've shown it with onchocercosis, we're showing it with malaria. You know, we have the problem with the narcotraficantes and all the rest of it, but there's still very, very good solutions. And those solutions we can help transfer in some fashion or another, modified or not, into other continents where it may still be a problem. So, sorry I ran a few minutes over, but any questions? Yes, that's highways, and that's to illustrate. You know, as I said, earlier, this route right here, that used to take up to 18 hours, and now it's a 4-hour drive.
Well, thank you so much, Dr. DeWar. And I know that we're past one, but we can still have one or two questions.
Okay. So is that going to stop now?
Good.
Okay, great. Especially in the first part of your talk, you gave the impression that most of the effort in getting rid of malaria in Mexico was through mosquitoes. Treatment of mosquitoes, at least your graphs tend to indicate that. So are you saying that we shouldn't concentrate on vaccines?
Well, I think it's both. You know, I mean, vaccines are great when they work right. Mm-hmm. But how long are you going to wait? I mean, you can't just sit around and wait. You have to do something. And this is sort of my passion and my love with working with my collaborators down there. They don't sit around. They have a whole group that's working on a vaccine. And, you know, in a much more rustic lab than what we have here. But they don't sit around and wait for that. You know, the whole point, we know how to get rid of malaria. We did it in the United States. We got rid of mosquitoes that had, you know, plasmodium in them. And we did it every time. I live out in Campeche Cove, and every time I see one of the sprayers go by, I want to stop them and scream at them because they're not doing it right. They're spraying in areas where it makes the minimal impact. And I think that's something that we can learn from that, from Mexico. You really do. I didn't show the picture, but 5 minutes later, I had a spray pack on me in my heels and pantyhose, going into a thatched roof house, spraying the walls down and putting lime on the walls. There's much. You really have to focalize your applications, and they're not doing that here. So.
One more question?
Either I bored you all or I answered all your questions. One or the other.
Oh, no, I wouldn't get up from my seat. It was just so interesting. Thank you so much for coming in, because a little token of gratitude for coming out, and I know that you have a very tight schedule.
Oh, thank you.
You will take home a Mardi Gras basket.
Thank you.